Shall I move on to the second part?
Yes, Paras.
So, second is about tenons patch graft. Various tissues and modalities are used to treat corneal perforations or impending perforations, as for example, use of tissue adhesives, amniotic membranes, conjunctival tissue, corneal tissue, or scleral tissue for anatomical and functional restoration and to salvage the eye in emergency situations. Recently, tenons tissue has been used to seal perforations into the cornea. This is an algorithm for tackling corneal perforation. You can divide it into central or paracentral or peripheral perforations. If it is less than, one can go ahead with synthetic tissue. If it is more than 3 millimeter, lesser than 4 to 5 millimeter, maybe with an iris prolapse or an iris seal, a tenons patch graft can work, or sometimes so the situations where we can use tenons patch graft be sterile corneal melts, post-chemical injury, traumatic corneal perforations, neurotrophic keratitis, peripheral ulcerative keratitis, leaking blebs, scleral melts, post-pterygium surgery, traumatic scleral perforations, and corneal fistulas. The advantages of using tenons tissue are many. It is available easily and in abundance. There is no need for donor cornea, hence eliminates risk of disease transmission as it is autologous, works as volume replacement, can fit any shape. It is repeatable, being avascular tissue does not increase the risk of immunological rejection after penetrating keratoplasty in future. You can see here a case with the corneal perforation, which was immunogenic. And you can see the small video where we are trying to harvest the tenons capsule from the supratemporal area. As the little larger size of a tenons is harvested than the size of the corneal perf. And you can use, brimonidine drops prior to the surgery, 10 minutes prior, so that there is less bleeding. It's important to release signage here with a spatula, reform the anterior chamber, and I'm trying to stuff the tenons tissue into the perf, as you can see with the corneal spatula. Once some amount of tissue has gone in, you can use the fibrin glue 1 and 2 components and suture it with onlay suture stenonylon to secure the tenons patch into the position. You can put here, I've tried to put 2x sutures, onlay sutures to cover that area. Sometimes you need to put 3x sutures or 4x sutures to secure this carefully. Once that is done, a BCL is put. This is a post-op appearance of the same patient, 4 weeks. If you look at the literature, one of the large series was published by Delhi group, Professor Mehta Sharma and Rasik Vajpayee. It was a retrospective case series where they analyzed 31 cases. They used technique of tucking the tenons tissue in a peripheral stromal pocket, which was created at the age of corneal perforation to prevent development of adherent leukoma. They also used sutures to secure the tenon patch graft, which prevented graft ectasia and yielded greater success rate in 82.7%, as against the previous paper, which was published by another group, where they had a 6-year retrospective study involving 28 eyes. They secured tenon patch graft with cyanoacrylate tissue adhesive as against sutures and applied a BCL, but they had lesser success rate as there were a lot of, as you can see here in schematics, there were a lot of adherent leukoma because they could not secure that area so very well in most of the patients. Recently, a paper published by LVPI group has shown long-term outcome of tenons patch graft in corneal perforation secondary to neurotrophic keratitis, and they have showed serial high-resolution OCT pictures, and they did cataract surgery in the same patient post tenon graft after 15 months, and that area could sustain the pressures of dynamics of phacoemulsification. That is very heartening to learn. So to summarize, tenons patch graft is inexpensive, it is easily accessible, and surgical technique is easy with onlay sutures. Effective in sealing large perforations of 6 millimeter in diameter. It integrates well into the host cornea and serves as a good scaffold for the epithelium to grow over it, resulting in a regular anterior corneal surface. It also eliminates the risk of disease transmission and dependency on eye banks. It harbors autologous fibroblasts that aid in its integration into host cornea without causing extensive scarring and vascularization. And it can allow possibility of corneal transplant with better outcomes. Thank you so much for your kind attention.